Hope you got it, right?
Yeah.
Okay.
Parimal sir, it's live.
Oh, good evening, everyone. Good evening, all doctors, and good evening, all healthcare practitioners. So we are glad to that you are for the interview. Welcome you for this interesting webinar on recent advances on SGLT2 inhibitor. Today we have one of the eminent speaker, Dr. Srinath, who will be speaking on the cardiorenal connection and diabetes, early opportunities for intervention. So I will just formally introduce Dr. Srinath sir. Sir is a MD/DM endocrinologist. Sir is currently a consultant endocrinologist at Caritas Hospital, Kottayam. Sir is also having various research and publications on his name. As I told you that Sir will be highlighting on the cardiorenal connection and diabetes, early opportunities for intervention in the light of recent advances on SGLT2 inhibitor. So over to you, sir. You can start sharing your screen now,
Okay, thank you
and you
very
can
much.
start your session.
Thank you, Parimal, for that brief introduction. So, as Parimal told, today's topic is regarding the cardiorenal connection and diabetes. What are the early opportunities for intervention? We all know that with regard to diabetes, the most dreaded complications are related to heart and kidney. So definitely we should go deep into each of these complications of diabetes. So initial few slides is just epidemiological slides. So we all know that one the disturbing truth, and that is India is going to become the diabetes capital of the world by around 2045. So you can clearly see the rising trend of diabetes in India when compared to 2017. It is very much high. We are expecting to be high in 2045. And here on the right hand side, you can see the prevalence of diabetes in rural population versus urban population. In this slide, you can see that in rural population, the prevalence of diabetes is less compared to the urban population. But the recent ICMR data, which is not published, which is just going to get published, it shows that in Kerala, there is no much difference in the rural versus urban population. Prevalence of diabetes in the rural and urban population comes around roughly around 24 to 25 percentage. So regarding the glycemic control, it is very much sad to say that around 67% of the patients are not reaching their HbA1c targets. You can see that the mean fasting plasma glucose is around 148 milligram per DL, and the 2-hour postprandial plasma glucose is around 220 milligram per DL, and HbA1c comes around 8.2 percentage. So only 33% of the diabetic population had HbA1c of less than 7 percentage, and coming to PPG, around 70%, 63% of diabetic population were above the target PPG of 180 milligram per DL. So, when coming into the details of diabetes, we should know about the specialties of Indian phenotype, or we can say that South Asian phenotype. So, we all know that Indians, I hope everyone may be aware of the YY paradox, comparing the BMI and the visceral adiposity of Indian origin and a Caucasian origin. So even if the BMI is same in both maybe both in population, but the Indian subject or in South Asian subject may be having high abdominal obesity. So Indian phenotype is characterized by abdominal obesity. More than 50% have high abdominal obesity, and in addition to that, 71% are hypertensive also. So coming to the risk, there is a twofold increase in the risk of cardiovascular complications, and 40 to 70% diabetic population have increased risk of renal complications. So what is the relationship between the cardiac and renal pathophysiology in type 2 DIA? When coming into this topic, we can see that in the slide, it is given as a cardio-renal risk factors. So Risk factors are common for both cardiac and renal complications. So the first and foremost risk factor is diabetes itself, uncontrolled glycemic levels. Then comes smoking, obesity, hypertension, dyslipidemia, genetic risk factors, as well as acquired risk factors. So all these risk factors in combination can lead to glomerular as well as interstitial damage, leading to chronic kidney disease. And it can also increase the ischemic risk and causes left ventricular hypertrophy, leading on to heart disease. So, if you see how much patients, diabetic patients, are getting admitted for heart failure or with regard to CKD, uh, hospitalization for heart failure cases, it is around 44%, though more than 50% patients who are admitted for heart failure cases are non-diabetic. And coming to CKD, it's around 48% of the diabetic population are progressing to chronic kidney disease stage. So at this point, I should tell something about the sodium glucose cotransporter 2 inhibitors. So patients with type 2 diabetes mellitus have high residual risk for the development of cardiovascular complications and diabetic kidney disease progression. So the various trials have shown that SGLT2 inhibitors have consistently reduced the risk of hospitalization for heart failure, and also it reduced the progression of diabetic kidney disease, and in some cases it even showed a regression to normalcy or regression from macroalbuminuric state to microalbuminuric state. So when we uh, see a diabetic patient and before starting the anti-hyperglycemic agents or anti-diabetic medications, we should consider several factors like metabolic requirements, safety of the drugs, safety of not being hypoglycemia, like that. And also, we should also check in the presence of background cardiovascular disease, presence or previously admitted for heart failure, or is there any renal complications also. So, what is the mechanism of action of SGLT2 inhibitor as a whole? We all know that almost 100 the whatever glucose is excreted through or excreted through the glomerulus, it is being reabsorbed in the proximal tubules by two transporters, of which SGLT2 is the most important transporter, which helps in the reabsorption of glucose from the proximal renal tubule, and a small fraction is also reabsorbed by the SGLT1 transporter. SGLT1 is mainly seen in the intestine. The small fraction is seen in the renal tubules also. So, in a diabetic patient, when we are prescribing Dapa glucosin or any other glucosins, it causes reduced glucose reabsorption from the proximal renal tubule. And as a result, the patient will excrete more glucose in his or her urine. And roughly, it is estimated that around 70 gram of glucose is being excreted per day, and it corresponds to around 280 kilocalories per day. So, we should know about the special features of SGLT2 inhibitors. The first is it will cause weight loss. As I already told, it will cause urinary glucose. It will cause increased excretion of glucose through urine, leading on to increased calories through urine, roughly around 280 calories per day. So by causing such calorie loss, it will lead on to weight loss, and it has got potential to reduce blood pressure because of the natriuretic as well as osmotic diuretic effect. And they are also uricosuric. And the uricosuric action is because of the inhibition of the tubular urate transporter, URAT1, and also it stimulates the uric acid secretion by the facilitating GLUT9 transporter. And the most important feature of SGLT2 inhibitor is that it will not cause hypoglycemia because the glycosuric effect will disappear when the blood glucose level reaches below 70 milligram per dl. This is because there is a transport capacity residual action in SGLT2 transporters, and also these drugs leave metabolic counter-regulation intact. And by reducing hyperfiltration, it will also reduce the GFR from hyperfiltration stage to normal stage. So what are the extra advantages of giving gluflozins? One is it causes weight reduction, it causes BP reduction, it causes less hypoglycemia, it is cardiovascular, with regard to cardiovascular safety, it is safe, and it has also got a proven renal actions. So just summarizing the key physiological effects of SGLT2 inhibition, by causing glycosuria, it reduces hemoglobin A1C, it reduces glucotoxicity, and it reduces the body weight. And by causing natriuresis and by increasing osmotic diuresis, it reduces the plasma volume, it reduces the blood pressure, and it also reduces glomerular hyperfiltration, thereby it reduces the intraglomerular hypertension. So at this point, I would like to tell one more thing. Comparing diuretics and SGLT2 inhibitors, that diuretics causes reduction in blood volume mainly by reducing the intravascular fluid. But when it comes to SGLT2 inhibitors, it is by decreasing the interstitial fluid, it reduces the plasma volume. So these are the beneficial effects of SGLT2 inhibitors. In the kidney, it causes afferent arteriolar vasoconstriction, and thereby it causes near normalization of the glomerular filtration rate, and it also reduces the risk of nephropathy. And through its mechanism, it causes increased glucose and sodium excretion, which leads to a decrease in blood glucose level, decreased plasma volume, decreased blood pressure, and decreased arterial stiffness. And as a result of these effects, the cardiovascular events and the risk of hospitalization for heart failure also decreases. Coming to the metabolic effects in pancreas, it increases the beta cell function by reducing glucotoxicity, and at the same time, it will also increase glucagon secretion. And coming to muscle, it increases insulin sensitivity, mainly by promoting the GLUT4 translocation, thereby the uptake of glucose will be more. And coming to liver, it increases hepatic glucose production. It also stimulates the glucagon secretion. So, as I already told, the gliflozins will cause afferent arteriolar constriction. So the pathology in diabetes is that in diabetes there will be afferent arteriolar dilatation leading to increase in intraglomerular pressure, as a result of which there will be more sodium glucose co-transport. And this effect of diabetes is inhibited by SGLT2 inhibitors by causing afferent arteriolar constriction. And coming to the effect on heart, it decreases the LV wall stress, decreases preload, decreases afterload. And coming on to the myocardial energetics, it is assumed that SGLT2 inhibitors have got a direct effect on myocardial energetics and metabolomics, and mainly because of its action on myocardial sodium hydrogen exchange transporters. So there are a number of SGLT2 inhibitor cardiovascular outcome trials, the CVOTs of SGLT2 inhibitors. The first one is the EMPA-REG outcome with empagliflozin. And the main point of EMPA-REG outcome is that almost all the subjects had one or more cardiovascular events prior to the trial. That means it is a secondary prevention trial. So when we look into MACE and risk of hospitalization for heart failure, right from the beginning, in the graph, you can see that even by 2 months, the distinction between placebo and empagliflozin is very much evident. And in the 3-point MACE, there is a 14% risk reduction with empagliflozin, and hospitalization for heart failure, there is a 35% risk reduction in patients who are on empagliflozin. The similar study with canagliflozin, it is a CANVAS program. Here also, the effect of canagliflozin is very much evident. 3-point MACE is reduced by around 14%, and the hospitalization for heart failure is reduced by 23%, 33%. And the difference between CANVAS and EMPA is that in CANVAS, 34% of the subjects were included as a primary prevention trial because they were not having any prior CV events, but definitely they were having some risk factors, multiple risk factors for the cardiovascular disease. And 66% had uh, uh, prior CV events. And the declare TIMI trial, the primary endpoints, with declare TIMI, it was found that the hospitalization for heart failure, there was definitely a of 17%. Coming to the 3-point MACE, even though it was not found to be superior to placebo, definitely it was found to be non-inferior to placebo with a risk reduction of 7%. And in the declared to me, composite renal endpoints were also looked into, which showed a 24% reduction in the secondary composite renal endpoints, which were a 40% persistent decrease in EGFR by less than 40%, end-stage renal disease, and renal or cardiovascular death. And in declarative itself, the effects of dapagliflozin were achieved on top of 80% use of RAS inhibitors. Patients were on either AC inhibitors or ARBs. So, what are the key safety parameters when we look into the dapagliflozin? And the declarative trial, various safety parameters were looked into, and out of which the important one they came across were the adverse events leading to drug discontinuation, diabetic ketoacidosis, and genital infections. And we all know that with regard to canagliflozin in the CANVAS program, the amputation rate was higher in patients who were on canagliflozin, but nothing like that was seen in the declarative trial. So summarizing the declarative trial, it is the largest SGLT2 inhibitor trial, which included broad representation of primary and secondary prevention patients. And the dapagliflozin reduced cardiovascular disease and hospitalization for heart failure, and was safe with regard to 3-point MACE, and it appeared to reduce the renal events. And the reduction in the cardiovascular disease rate and the hospitalization for heart failure was consistent regardless of baseline atherosclerotic cardiovascular disease or heart failure. And dapagliflozin was safe and generally well tolerated in the trial, even though there were increased genital infections and some cases of diabetic ketoacidosis were also reported. But no difference was seen in amputation rate, fracture rate, or in occurrence of stroke. And there was definitely a reduction in occurrence of hypoglycemia, acute kidney injury, and bladder carcinoma. So when we look into in whom we can start SGLT2 inhibitor, definitely if the in patients and diabetic patients, if the atherosclerotic cardiovascular disease predominates, if heart failure predominates, if chronic kidney disease predominates, then we can directly start SGLT2 inhibitors after metformin. And even if there are no previous history of atherosclerotic cardiovascular disease or heart failure or chronic kidney disease, then we may start SGLT2 inhibitor with the intention of preventing all these complications in diabetic patients. Little detail about dapagliflozin in heart failure. This is a Dapa HF study which showed with regard to cardiovascular death and hospitalization for heart failure in patients who were on dapagliflozin. There was a relative restriction of 26%, and the NNT, that is the number needed to treat, was 21, which means that only 21 patients were required to after treating to prevent one the CV event or to prevent one hospitalization for heart failure. Only 21 subjects were needed to treat. And with regard to all-cause death, here also it was dapagliflozin was found to be superior to placebo with a relative restriction of 17%. So the next question arises is the benefit of dapagliflozin with or without diabetes? To answer this question, one study was conducted, and we should all feel proud because our one Indian is also in this study, that is Dr. Subodh Verma. And this study looked into the effect of dapagliflozin on worsening heart failure and cardiovascular death in patients with heart failure with and without diabetes. So when they looked into the details of the study, even if the patients had diabetes or they did not have diabetes, the effect of dapagliflozin was found. The dapagliflozin was found to be beneficial in patients with diabetes and in also in patients without diabetes for reducing the risk of hospitalization for heart failure. Even though they looked into HbA1c trials in patients without diabetes at baseline, the result was found to be statistically non-significant. And what is the effect of dapagliflozin in those with new onset diabetes? So in Dapa HF study, around 2,600 subjects had no diabetes in both visits. In both visits 1 and 2, HbA1c was less than 6.5%. That comprised around 55% of the study population. And so in pre-diabetes group, the placebo-adjusted delta HbA1c was found to be minus 0.04 percentage. That means HbA1c reduction was seen by 0.04 percentage. And in normoglycemic subjects, the similar reduction was around by the HbA1c reduced by around 0.05 percentage in normoglycemic subjects. And and the incidence of new onset and type 2 diabetes in dapagliflozin arm versus a placebo arm. And in this data, they showed that there was a 32% risk reduction of developing diabetes in those who were on dapagliflozin. So they concluded that the dapagliflozin decreased the incidence of type 2 diabetes by 32% in 2,600 participants in the DAPA-HF trial who did not have diabetes at the baseline. And this effect was principally driven by participants who had pre-diabetes. And the major role of dapagliflozin in patients with heart failure with reduced ejection fraction is to reduce the cardiovascular mortality and worsening of heart failure. Decreasing the incidence of diabetes may also be considered as an additional benefit because we all know that if the patient contracts diabetes, then it also becomes a risk factor for developing cardiovascular mortality as well as heart failure. So these observations were made. DAPA-HF is a first trial to demonstrate a diabetes prevention effect from an SGLT2 inhibitor. We know that previously we used insulin, ecarbose, pioglitazone for diabetes prevention trials. So DAPA-HF is the first trial to demonstrate such a diabetes prevention effect from an SGLT2 inhibitor. And in contrast to other diabetes prevention trials, HbA1c was minimally reduced by dapagliflozin in non-diabetic subjects at baseline. And this may dispel the concerns about merely masking the development of diabetes. And it is the first medication demonstrated to reduce both incident type 2 diabetes and mortality in a single trial. While it is very unlikely to be the cause and effect of the drug, the relationship between these two events requires a further study, and hopefully it will come up. So what are the renal benefits of SGLT2 inhibitors in SGLT2 inhibitors? So first we will consider the canagliflozin. The primary is the credence trial, a primary composite outcome and renal specific composite outcome. Definitely it was shown that canagliflozin was very much beneficial when compared to placebo in reducing the risk of renal events. Especially in the occurrence of end-stage kidney disease and the need for dialysis, need for kidney transplantation, or occurrence of renal death, all were statistically significantly reduced in patients who were on canagliflozin. So the risk of kidney failure and cardiovascular events was lower in the cana group than in the placebo group at median follow-up of 2.6 years. So now we have the recently published DAPA CKD study that which mentions the effect of dapagliflozin on renal outcomes in patients with and without diabetes. Here, the primary composite and the renal specific composite outcomes were looked into, which were the sustained decline in EGFR by more than or equal to 50%, end-stage kidney disease, then renal or cardiovascular death. Both the primary composite outcome and the renal composite outcomes were reduced in the DAPA arm, and the relative restoration was found to be 44%. And with they also looked into all-cause mortality with dapagliflozin compared to placebo. There was a 31% reduction in all-cause mortality. So if we summarize DAPA CKD, we can say that there is a 39% relative restriction for the primary composite endpoint and 44% relative restriction in the renal composite outcome. And with regard to cardiovascular death or hospitalization for heart failure, patients who were on dapagliflozin had a 29% risk reduction. And with respect to all-cause mortality, 31% relative risk reduction was seen in DAPA arm. So this treatment effect was seen in both patients with and without type 2 diabetes mellitus, and also when they looked into different groups varied by the baseline EGFR and urine albumin creatinine ratio, the results were similar. And it once again confirmed the known safety profile of dapagliflozin. And it also, the DAPA CKD study builds upon the evidence for dapagliflozin in the prevention of hospitalization for heart failure and worsening of renal disease, as seen in DECLARE TIMID trial, and also reduction in the risk of worsening heart failure and cardiovascular death in DAPA-HF trial. So the safety outcomes once again confirms that Dapa is safe when compared to placebo. So at this point of time, we have three major trials of dapagliflozin. The first one is a declare timid trial, which consisted of 17,000 subjects. Then DAPA HF study with 4,700 subjects, and DAPA CKD study with 4,300 participants. So the patient population differed a little bit in all the three trials. In declared timid trial, patient population 40% had previous atherosclerotic cardiovascular disease, or and 60% had multiple risk factors. And in that participants, only participants with EGFR more than or equal to 60 ml per minute were considered. In DAPA HF study, patients with heart failure with reduced ejection fraction were also included, and also EGFR was the inclusion criteria for EGFR was brought down to more than or equal to 30 ml per minute. And in DAPA CKD study, CKD patients were also included with EGFR also a little bit decreased, 25 to 75 ml per minute per meter square. And the mean EGFR of participants in declared timid trial was 85, and in DAPA HF it was 66, and in DAPA CKD it was 43 ml per minute. And definitely all these studies confirmed the beneficial effects of dapagliflozin in preventing the recurrent hospitalization for heart failure, and it was found to be non-inferior with regard to 3-point MACE in declared timid trial. And in DAPA HF and DAPA HF trial, it was found that it reduces the risk of hospitalization for heart failure, also reduces the cardiovascular morbidity and mortality in both diabetic as well as non-diabetic subjects. And in DAPA CKD study, it was found that it reduced the renal events and also reduced the risk of cardiovascular death and hospitalization for heart failure. And all the three studies confirmed that Dapa is relatively safe drug, and it can be given in almost all subjects, type 2 diabetic patients. Now we'll go through a few diabetes guidelines. The first one is the ADA, EASD, and guidelines. 2020 modifications have come, and the one of the most important modification compared to the previous statement is that at first we have to give metformin and lifestyle modification for every subject unless the patient is intolerant to metformin, and after metformin we have to categorize the patient. We have to look into whether the patient has established atherosclerotic cardiovascular disease or CKD initially. And if the history is there, if the patient had a prior history of cardiovascular disease or prior history of chronic kidney disease, then we should go for, after metformin, we should go for either GLP-1 receptor analog or SGLT2 inhibitor. And if the patients have no previous history of atherosclerotic cardiovascular disease or chronic kidney disease, then we should look into a few other categories, like is there any compelling need to minimize hypoglycemia? In that case also, SGLT2 inhibitor comes in the top. And if there is a compelling need to minimize the weight gain or promote weight loss, in that category also, SGLT2 comes in the top along with GLP-1 receptor analog. And only a category where SGLT2 goes down is when cost is considered. When if the cost is a major issue, then SGLT2 inhibitor goes below sulfonylureas and thiazolidine diones. So for the first line therapy, if the patient is drug naive and if there is history of atherosclerotic cardiovascular disease, or there is high risk or very high risk of cardiovascular disease, then definitely we should go for SGLT2 inhibitor or a GLP-1 receptor monotherapy. Later on, we may add metformin for that patient. And if the patient is already on metformin, then as I already told, we should think of adding SGLT2 inhibitor or GLP-1 receptor analog after metformin. So in ADA guideline, the same thing is stated. If the patient has history of a heart failure or a CKD, particularly if the ejection fraction is less than 45%, and if the EGFR is 30 to 60 ml per minute, that means CKD stage 3B to stage 3B and 3A. And in that case, also we have to think of adding SGLT2 inhibitor. And if the urine albumin creatinine ratio is more than 30, and if that means it is in the microalbuminuric state, And if the patient is in the macroalbuminuric state, that means more than 200 milligram per gram of creatinine, then definitely we should think of adding SGLT2 inhibitors. So both the guidelines agree that SGLT2 inhibitors are important drugs for the treatment of diabetes mellitus, but they diverge on placing the drugs in the algorithm of treatment, and the intent is same, even if the details differ slightly. So I think the message is very much clear. If the patient is having a previous history of atherosclerotic cardiovascular disease or chronic kidney disease, after adding metformin, we should definitely think of adding SGLT2 inhibitors or GLP-1 receptor analogs. And in our setup, it is most of the patients will prefer tablets rather than going for one more injection with GLP-1 receptor analog. So after metformin, SGLT2 becomes the drug of choice for patients with CKD or patients with a previous history of heart failure or previous history of atherosclerotic cardiovascular disease. And this is the ACC AHA guideline. And initial are the lifestyle modifications recommended. Dietary pattern should be followed. Diabetic diet should be followed. And also they should work out for 150 minutes per week with moderate intensity physical activity. And after that, when coming to the drug therapy, it clearly states that who requires glucose lowering therapy, despite initial lifestyle modifications and metformin, it is reasonable to initiate SGLT2 inhibitor or GLP-1 receptor analog to improve the glycemic control and to reduce cardiovascular disease risk. So this is the algorithm, the same thing mentioned here. So what is the take on the early combination therapy for diabetic patients? In ADA position statement, it is stated that if the patient's baseline HbA1c is more than 9%, then there is a low probability of achieving near normal target with monotherapy, with metformin or with DPP-4 inhibitor. So in such patients, for initial therapy, we may go for a combination therapy with two agents. And similar thing, AAC treatment guidelines states that treatment naive patients with a high HbA1c of more than 7.5% should be initiated on combination therapy. And patients who are not at goal on monotherapy should proceed to dual therapy at 3 months. And the preferred add-on to metformin oral treatment is an SGLT2 inhibitor, possibly because of more CV benefit with SGLT2 inhibitor. So ESC position statement on SGLT2 inhibitor. It recommends the use of SGLT2 inhibitor early in the course of management of patients with diabetes and cardiovascular disease to reduce the cardiovascular as well as total mortality. So the ESC guidelines in 2019 practice update, it has recommended that empagliflozin should be considered in patients with type 2 diabetes in order to prevent or delay the onset of heart failure or prolonged life. This guideline was put forward in 2016. And in 2019, canagliflozin and dapagliflozin also came into the limelight, and they recommended that both these drugs should also be considered for patients with diabetes and either established cardiovascular disease or whom are at high cardiovascular risk in order to prevent or delay the onset and also to reduce hospitalizations for heart failure. And at this point, there is no specific recommendations for the use of SGLT2 inhibitors in patients with SGLT2 with established heart failure. This was in 2019, but the scenario has changed now. And Canadian Cardiovascular Society guideline update in regarding the SGLT2 use. Uh, the Canadian guidelines states that if the patient is having diabetes or even if the patients are not diabetic, we should definitely think of adding dapagliflozin or any other gliflozins in patients with mild to moderate heart failure, mainly because of reduced LV ejection fraction, that means less than 40%, to improve the symptoms and also to improve the quality of life and to reduce the risk of hospitalization and cardiovascular mortality. So the evolution is very interesting. At the time of launching of this SGLT2 inhibitor, it was considered as an effective glucose-lowering agent that work in an insulin-independent fashion. That is the most important thing. Because of the insulin-independent action, it had no hypoglycemia, and it was also associated with weight loss and BP lowering because of its mechanism. It causes calorie loss as well as it causes more because of its osmotic diuretic action and also because of its natriuretic action, it causes BP lowering. And with the EMPA-REG outcome and the CANVAS program, its beneficial action in the heart was was evident after the EMPA-REG outcome and the Canvas program. It caused reduction in the 3-point MACE and also hospitalization for heart failure, and it proved to be more beneficial in reducing the cardiovascular mortality in patients with diabetes and established cardiovascular disease. And after that, the declaratomy came. The same recommendations were made after the declaratomy, and it was done in broad population of patients with type 2 diabetes. And post Dapa HF, it was the role of dapagliflozin came in the treatment of heart failure in patients with heart failure because of reduced ejection fraction in patients with or without diabetes. Till then, the drug was considered to use in diabetic population, but with DAPA HF study, it was found to be useful in patients without diabetes also. So currently, what are the indications which are approved for SGLT2 inhibitor use? For dapagliflozin, definitely type 2 diabetes, and also in patients with type 2 diabetes with established cardiovascular disease or with multiple cardiovascular risk factors to reduce the risk of hospitalization for heart failure, and in patients with heart failure with reduced ejection fraction with or without diabetes to reduce the risk of cardiovascular death and hospitalization for heart failure. And for empagliflozin, it is type 2 diabetes mellitus, and to reduce the risk of cardiovascular death in adult patients with type 2 diabetes mellitus and established CVD. And canagliflozin for type 2 diabetes to reduce the risk of major adverse cardiovascular events in adults with diabetes and established cardiovascular disease. And with current trial, it was the indication was modified to slow the progression of diabetic nephropathy and to reduce the risk of hospitalization for heart failure in patients with type 2 diabetes mellitus and diabetic kidney disease. So we all know that this diabetes, cardiorenal pathophysiology, and the heart failure all acts as a continuum. So with these three major landmark trials with dapagliflozin, declaratomy, DAPA-HF, and DAPA-CKD, it has proved to be beneficial in primary prevention of the complications of diabetes, and also it is very much beneficial in secondary prevention also. And with regard to the atherothrombotic continuum, renal continuum, heart failure continuum, in all these things, the dapagliflozin was found to be beneficial through these three landmark trials, declaratomy, DAPA-HF, and DAPA-CKD. So thank you for the patient hearing.
No, thank you, doctor. There are a couple of questions asked by the audience. What is a suitable time to start SGLT2? Sir?
Suitable time with regard to diabetes, I think. So for a treatment naive patient, if the patient is obese or if the patient is having a previous history of cardiac disease or chronic kidney disease or heart failure, then it is most suitable time to start SGLT2 inhibitor in a diabetic patient. And at the time of the starting this SGLT2 inhibitor, we should counsel the patient that we should tell them the mechanism of action of this drug, meaning that it is acting by increasing the glucose excretion through urine. So we have to drink plenty of water, and also we have to maintain proper personal hygiene. And with regard to the time of taking SGLT2 inhibitor, I usually give SGLT2 inhibitor in the morning time.
So, second question is, what happened to glucodynamics when Dapa was used for heart failure in non-diabetic patients?
Can you repeat the question?
What happened to glucodynamics when Dapa was used for heart failure in non-diabetic patients?
Okay. It was clearly mentioned in the Dapa HF study. When in the Dapa HF study, around 55% of the study population were non-diabetic. Non mean they were not diabetic. So when dapagliflozin was used in that population, it was found that the risk of development of diabetes was reduced in such patients. That was one. And also the HbA1c reduction was not that significant in such patients. For those who were not diabetic, the HbA1c reduction was not that significant. Reduction was around 0.03 to 0.05 percentage, but still there was the relative risk reduction of diabetes, the development of diabetes in DAPA arm was significant when compared to the placebo arm.
So the third question asked by Dr. Bibi Chako, how earlier dapagliflozin can start for diabetic patients to get maximum benefits?
As early as possible. That's the only thing I can say. If the patient, the guidelines say that we should start with metformin, and if the patient is intolerant to metformin, then we can go for the second line drugs as a first line therapy. So if the patient is tolerant to metformin, then we can start on metformin, and after that we can look into the HbA1c, the fasting plasma glucose, and ppbs after 3 months. And if the desired reduction is not seen in FBS, ppbs, and HbA1c, then we may think of adding the second line drug. And among the second line drug, SGLT2 inhibitor, we should think of starting SGLT2 inhibitor. So we can start as early as possible. There is no issue in that. And definitely with the latest trial, it was shown that we should target maximum glycemic control in the first year itself to prevent the development of complications later in the patient's life. So at the first instance itself, we should go on for a strict glycemic control. So if it is not obtained with the with monotherapy, then definitely we can go for a dual therapy. And in dual therapy, SGLT2 inhibitor is one of the most preferred agents.
So fourth question is Dr. Jacob Wright asked from Tiruvalla, how challenging is dapagliflozin for the renal impaired patients?
Dapagliflozin in the declared-TIMI trial, it was used in patients with eGFR more than 60 ml per minute. And later in the DAPA HF study, the cutoff was brought down to 30. And in DAPA CKD study, further it was brought down to 25. So it means that from the current trial, it was found that the canagliflozin is very much beneficial to patients with CKD. So I think that it is all because it is all because of the class effect of the drug. It is almost similar to all gliflozins. So both CANA and EMPA was used in patients with eGFR of 45. In the EMPA outcome and CANVAS program, the cutoff eGFR was 45, and later it was made to 30. So in patients with eGFR of more than 30, definitely we can think of using SGLT2 inhibitor, and it will improve the eGFR, and also it will improve the albuminic state. If the patient is having a macroalbuminuria, then it will either halt the progression of albuminic state, or even it may regress to microalbuminuria or normoalbuminuria. So definitely, if the patient is having eGFR of more than 30, we can try SGLT2 inhibitor.
Sir, another question is that is all SGLT2 having similar benefits? Your take on this?
Almost that's what I just told. I think all the benefits are class effects. For EMPA, for CANA, for DAPA, I think all the class effects. So there is no much difference in giving EMPA, CANA, or DAPA. So I think it's all the same.
Sir, the last question is how to take care of patients on SGLT2 in COVID-19?
Okay, that's a very interesting question. COVID era. First of all, if we keep aside all the medications or all other health conditions, the COVID-19 is more, we see that COVID-19 and its complications are more severe in diabetic patients, and also in patients with CKD, CLD, or any heart disease like that. So definitely we have to get good glycemic control for preventing the complications of COVID, even if the patient contracts COVID-19. So for that, we can use any drug, but preferably if the patient contracts COVID-19, then preferably we can go for insulin in such patients for that short period of time. That is because the treatment of COVID-19, we know that at the dexamethasone, we are using dexamethasone for patients with COVID-19. So in a diabetic, so even in non-diabetic patients, if we give steroids, then it may increase the sugar levels of subjects. So in diabetic patients, if we are giving dexamethasone, definitely their sugar levels will go up. And in such cases, we should use insulin to control the glycemic levels. And after that, we can switch back to the previous therapy. That can be a metformin, ST2 inhibitor, DPP4 inhibitor, anything like that. But if the patient contracts COVID-19, then it is suitable to use insulin in such cases.
Thank you, sir. On the behalf of Sun Pharma AVL Division, I would like to thank Dr. Srinath for this wonderful speech. Thank you, sir. Thank you very much.
Thank you, Shabri.
Yes, sir.
And thank you, Sun Pharma.
Thank you, sir.